dialogue about how we can help support you through this crisis. So the entire point of bringing all of us together is that we all need to work together towards solving this crisis. So I'm beyond thrilled that we have a pretty robust team here from the state of Oregon and from Jackson County Public Health. And I'm very grateful for everyone who shifted their schedules so quickly to be available today. And I'm going to go through and introduce them. So let's start with Jack Honey. Jack, what do you do for DHS?
Thank you, Mike. My name is Jack Honey, and I'm the administrator of the Safety Oversight and Quality Unit here at APD. So I work closely with Mike, and most of you, I think, know me and the work of my team. We are the survey unit and the group that does licensing and regulatory oversight for licensed settings.
Thank you, Jack. Rachel?
Hi, Mike. Good afternoon, everyone. My name is Rachel Kearns-Henry. I work with the COVID Response and Recovery Unit, which is a shared service between the Oregon Health Authority and the Department of Human Services, coming together to ensure we have a unified response. My role has been to serve as the Systems Integration and Policy Director. I work primarily with Mike and Linda and team to really ensure that we're bringing the full public health response, the OHA public health expertise and the DHS regulatory expertise together into our response. Thank you.
Jessica Soltesz?
Hi, my name is Jessica Soltesz. I'm the Community Support Services Director with the COVID Response and Recovery Unit. I work with Rachel, and my role is to make sure that the work that CREW, or the COVID Response and Recovery Unit, is connected to the field work that ODHS does, and making sure that those connections are being made.
Jessica McCormick?
Hi there. So I'm Jessica McCormick, and I am a Regional Emergency Coordinator for Oregon Regions 3 and 5 for Oregon Health Authority. And so those regions include Coos, Curry, Douglas, Jackson, Josephine, and Lane counties. And Douglas, if I missed Douglas. So I support those regions as a Regional Emergency Preparedness Coordinator, and also work with Jessica and Rachel as part of the COVID Recovery and Response Unit.
Thank you, Jessica. Jeremy?
Yes, hello, Jeremy Wolf. I'm the Deputy District Manager down here in Jackson and Josephine counties for our Aging and People with Disabilities offices. We have two offices in Medford and one in Grand Pass.
So in other words, he oversees all of the aging and people with disabilities staff that help place individuals into facilities. Elisa Williams, welcome. Introduce yourself, please. Okay, looks like a problem with Elisa. Let's move to the county. Jackson, can you introduce yourself, please?
Sure, thank you. I'm Jackson Bowers. I'm the Jackson County Public Health Division Manager. In terms of our involvement, we wanted to try to get everyone together. We're involved in COVID outbreaks and other outbreaks at long-term care facilities, but we're not the oversight agency. And I know personally I lack knowledge in terms of staffing, resources, rules, and so forth that long-term care facilities have. And so thanks for having us. Thanks for getting everyone together.
Thank you for being here. Jim.
I'm Jim Shames. I'm the Health Officer Medical Director for Jackson County. I'm a family practice doc, and I'm very interested in anything that can be done to reduce the morbidity and mortality with this vulnerable population that's being so impacted.
Thank you for being here. And my guess is that everyone knows Linda, but take it away, Linda.
Good afternoon, everyone. And this is Linda Kirschbaum with OHCA, Senior Vice President of Quality and Services. But we're just grateful that everyone was able to jump on and participate today. We've all learned quite well how to pivot and be flexible. So we appreciate that. And I just want to really thank Mike and Rachel. We work very closely on this coordination. Just want to make sure that you all know that we're hearing you, and we're really trying to figure out how we can best coordinate all the information and all the responses. And we're just here to support you all at this time. And we know that Jackson County is having some challenges, but we're here to support in any way we can. So thank you very much. And thanks to our partners at the agencies for your willingness to work with us on a continuous basis throughout this pandemic.
All right, thank you, Linda. So we have a pretty robust agenda, so we're going to need to ensure that we stay on point. And I'm going to ask Jessica McCormick to give an overview of what's going on in Jackson County first, from her
Sure.
perspective.
Thank you. Yeah, so my overview will include all of Region 5, so Jackson and Josephine counties included. So when I talk numbers, it's including both of those counties. So like I said in my introduction, I'm a regional emergency coordinator, and I support our healthcare coalition, which includes our hospitals, our EMS agencies, our local public health authorities, and our emergency managers. And so right now, hospitals across Oregon are experiencing a surge in COVID hospitalizations. And so that's not unique in Jackson and Josephine counties, but currently there are 54 hospitalized COVID positive patients in the region. 14 are in the ICU and 5 are on ventilators. We're hearing from both our hospitals and EMS agencies that they are struggling with staffing issues, as I know so many of you are as well. And then additionally, we've heard across the state and specifically in Jackson County that there are a large number of individuals who are currently hospitalized who no longer need hospital level of care and are waiting to be discharged into some form of long-term care facility. And so, as we're seeing these hospitalizations increase, staffing shortages due to, either staff being out because they are, have been exposed to COVID and have to isolate, or other just family reasons. We're just really as a healthcare coalition trying to help support that. And so, as we look forward into the winter months, we know historically we see an increase in hospitalizations due to flu or other respiratory like illnesses in the winter months. And so that's just something to keep in mind as we move forward and are looking into the winter months. And I'm really looking forward to collaborating with all of you on how we can kind of work together to solve this problem that really all of our healthcare agencies are experiencing at the same time.
Thank you, Jessica. So it's unfortunate that I needed to add this next agenda topic because we've invested so many resources in helping facilities be prepared for COVID. But we'd be remiss if we didn't take this opportunity to give you a quick reminder on how you can prepare for COVID entering your building. And my suspicion is that COVID is going to enter every single one of the buildings in your area. So I'm going to hand it off to Jack Honey to give a quick recap of what you should be doing to prepare for COVID.
Yeah, thank you, Mike. And yeah, I'll just take a minute or two to go over a few things that we've been seeing. The first thing, obviously, is, if you do get an outbreak in your building or even a single case, it's the decisions and the actions that you take immediately that really make a difference. And just a reminder to all of you as providers that both the Safety Oversight and Quality Unit and the Oregon Health Authority have developed tools that can be very useful and helpful for you to use. The OHA has developed the Long-Term Care Facility COVID-19 Response Toolkit, and SOQ has the COVID-19 Readiness Assessment, which is basically a checklist. I know that we have made these available to you, but just a reminder that you can contact your OPA or the program here at SOQ, and we can send you either of those and any resources that you may need. As we are going into buildings nowadays, this many months into the pandemic, unfortunately, with many buildings, we are seeing a few things that really could be done better. The most important thing, well, actually several things that are very important. One is staffing. We've been saying for months, sometimes when a building gets an outbreak, especially if it's a larger outbreak, you sometimes will have staff that will not want to work in your building or will refuse to work in a COVID positive building. We encourage you to train and retrain and educate and re-educate. Find out in advance, have those conversations with your staff, what it's going to look like if you have an outbreak. Reminder, once you get an outbreak, you will be issued an executive order, and those executive orders have certain requirements. One of the main requirements is that anybody who is suspected or confirmed with COVID does need to be isolated, and COVID positive residents will need to be cohorted, and along with that is dedicated staff. Buildings are most successful when they have had those conversations with staff in advance. How will you manage cohorting? Which staff will work where, and what will you do as providers to help keep your staff safe as well as residents? And unfortunately, we are also seeing a lot of PPE concerns still when we go into buildings. And it's not because staff are bad or not listening, it's because they're exhausted and moving very fast. And there are frequent changes in what's being recommended. So our recommendation is to cover PPE use at every staff meeting, have some form of observation on your floor on a daily basis, and just make sure that everybody is remembering. Put signs around, use guides, help do whatever you can to help your staff understand and remember the importance of using PPE. These are some of the top issues that we have been seeing. But again, I encourage you all to reach out to your OPAs and get those assessment tools if you haven't done one recently, and go do a comprehensive read through and walkthrough of your facilities, and do that frequently because things are changing very quickly. And we are hopeful that these tools will be helpful and useful for you. We are updating them as we do learn more or as things do come up. And again, we are the regulatory agency. As you all know, we are surveyors, but in this COVID pandemic, we all have the same goal in mind, which is keeping our residents safe and helping facilities to stabilize and get clear of outbreaks when they do happen. And of course, preventing them from happening in the first place. So please do not hesitate to contact the Safety Oversight and Quality Unit with any questions or concerns. We can help.
Thank you, Jack. All right, so then as your regulator, I want to make it very clear that evacuation to hospitals if you have a COVID outbreak is not appropriate. Every one of us has a responsibility to help with hospital capacity. If I need to be hospitalized today, if my mother needs to be hospitalized today, I think it's a very reasonable expectation that my local hospital is going to have beds available. So that means that we're only admitting people who really need hospital level of care. And then when they're ready for discharge, all of us, the collective, all of us, not one single person, have a responsibility to try and get that done as quickly as possible. So I want to allow Jackson County Public Health to give an overview of what they're seeing on the ground, including perhaps the hospital situation. So please take it away.
And I think I'll defer to Jim. Jessica actually summed it up pretty well in terms of what's happening in Jackson County. But Jim, I don't know if you have any other insights in your conversations with hospitals.
No, and I don't think in general what's happening here is unique to Jackson County. Wherever you all live, your local hospitals are probably getting pretty close to capacity. Your higher levels of care are being stretched. And what we're really noticing is how quickly the staff evaporates. Just like you said, Mike, not only are lots of staff getting sick, but they're also frightened and may not want to continue to work. Some of the staffing shortages that we've seen here locally are really frightening. You get a sense that the staff is exhausted. They're just right on the edge. So I don't know how that gets fixed, but it's worrisome to observe. My interest and the reason I'm really here is that the spread through the folks who are living in these facilities is so rapid that I think we ought to be doing everything we can proactively to prevent it from getting into the facility. As well as we do, it tends to come in from the staff, and we in public health can connect the dots. So we know about the birthday party that everybody went to, and then the families go out back to work, and they're working at facilities like these, and then off it goes. So I also think that maybe there's some way in which there could be continuing reminders and education that what you do at home affects what happens at work. And also just an opportunity for the different facilities to talk to each other. There's so many obvious lessons learned from the people that have just been through it that it would be really helpful if they could be communicating to the facilities that are, COVID naive, or at least that the folks living in the facilities are COVID naive, to explain what they learned the hard way so that it doesn't get repeated.
Okay, thank you. All right, so I wanted to give some situational awareness on what's happening with the long-term care facilities in Medford. So according to our licensing records, we have 30 unique licenses of the large long-term care facilities. 14 of them have executive orders. So an executive order is placed whenever there is a suspected or confirmed case of COVID-19 in either a staff member or a resident. And I can tell you that the level of severity varies amongst those 14, but there are some really bad ones. We have been doing crisis management with some of these buildings. So I wanted to, Jack and I wanted to dispel a myth today that an executive order prevents a facility from admitting. It does not. It prevents you from admitting without authorization. So on this agenda, you can see the email address where you can request to admit people if you have an executive order. And basically, we needed this function in place because we want to have assurance that a facility is going to be able to manage the situation. So if they're COVID naive, bringing in a COVID positive resident, are they going to be able to manage that so that it doesn't spread? Or vice versa. They have a lot of COVID in the building and they want to admit a negative individual. Are they going to be able to keep that person safe? So those types of safeguards are reviewed prior to admission approval, but it is done quite regularly. So we hear all the time facilities, because I get all types of complaints, as you can imagine. And I hear, the facilities are saying they can't admit anyone because they have an EO. Well, that's not true. There's more to the story than that. So want to make sure that everyone is aware of that. We know, moving on to the next topic about the staffing crisis, we know what is going on. It's not unique to your area. It does seem to be more acute in your area. And I think what we're what we are faced as a governmental agency is we have very limited ability to help in this area. Rachel Currens Henry is working with a team. Do you want to recap some of the work that you're trying to do to get ahead of this, Rachel?
Absolutely, Mike. Thank you very much. Jessica McCormick started off by stating that she was with the Regional Emergency Coordination Unit at the Oregon Health Authority. And I want to just acknowledge that same team that Jessica's part of also has medical surge planners and is doing work statewide as we go into surge to really assess what are some of the broader staffing and workforce issues that we can be thinking about as a state to be prepared. So we are working together to really understand with those teams what are the specific challenges that we are having in long-term care settings, and how can we continue to see if we have how do we have backup plans and support. I just want to acknowledge, while we need to have we're doing our best to have backup plans, meaning if there was a understanding if the state needed to have emergency staffing contracts in place to fill in emergencies, or having EMS, ambulance drivers or others available to assist. Those are an extreme. We really need to make sure, as Jack had said and Mike had said at the very beginning, ensuring that facilities have their staffing plans, that they are working to ensure that they have staff ready to go for cohorting, that you're potentially looking at needing to increase pay at times to ensure that you're getting staff in place when you do have an outbreak, and that you are potentially looking at collaborations across your different partners. I'm going to get to that further. How can we assist in that regard? We have Connect to Care Jobs, a staffing resource and house. We have Serve Or, which is a site for volunteers. We're continuing to use some of those tools. How do we get some of those volunteers, those individuals who are out of work right now? Can we try to get them into CNA training programs? Can we try to ensure that we're increasing the workforce to ensure that we have capability to assist? These are all of the types of efforts that we're working on at the state level to ensure that we have support, and we want to ensure that we're doing that. However, again, this is for the extreme, for the emergency. I cannot reiterate enough. Part of this is we can't just rely on that. We're going to need to have at the regional level coming together, just like we're doing with hospitals as well, coming together to see what do we do in an emergency, because at the end of the day, we're all looking at the same pool of workers, and we have to figure out how we help one another. And that's why we're starting these dialogues, because even if we get these contracts in place and can have them ready to go, we don't know if it will be enough, and we still need to rely, and we can't just rely on them. So those are some of those examples, Mike, and I can happily give more, but I don't want to make promises, and I want to make sure that our message today is not about what is the state going to do, absolutely, but more about what do we need to do together with all of you.
Yeah. Perfect. Thank you, Rachel. And then some of you, or probably all of you, are aware that we have contracted with 2 entities up in the Portland area to provide long-term care for COVID positive individuals. We've had a request for applications for new providers open for almost 3 months now. I am still interested in expanding, especially in the Medford area, other areas of the state as well. And so here is my contact information if you are interested in setting up COVID positive capacity, which can be used as a pressure relief from other long-term care facilities. It can be a safe place to discharge from hospitals. We're also admitting people directly from their homes. I mean, it's been really successful, but we need more. So that's my pitch to all of you. So for today, this is the meat of our discussion. This is why we brought all of us together. This is why you have so many people on the phone today. We need to solve this together. I'm begging you to look at your peers as friends and not competitors, and figure out how we can solve this problem together, because we are still at the early stages of the surge. It's going to get worse before it gets better. And you may be sitting pretty with a COVID naive building right now, but the chances are that that's going to turn in the future, and you're going to need assistance in the future. And the concept that we're pitching to you is that you should, because we have the leaders on this call, that the leaders need to lead. They need to talk to their other leaders and say, in a jam, this is how we're going to solve the problem. We're going to share staff. We're going to discharge residents to other long-term care facilities. These are our initial ideas. We don't know what the ultimate solution is, but you've got a lot of people on this call today with the same interests. So I'd really like to open up the dialogue to hear any commitments that any of you can make in your area, and telling us, what do you need in support from the state? And to the extent it's possible that we can provide that support at the state, we are going to invest the resources to get it done. This is of the utmost importance to us. So, Catherine, I'm not sure if you're going to be able to facilitate the dialogue. If Linda wanted to prompt questions to all of us.
Sure.
Hang on there, yes. I think if folks want to, can we let them unmute themselves, Catherine?
This is a webinar, so they can't unmute themselves.
Well,
so type them into the chat if you can.
In the question box. And, you know, I think just to kind of kick that off a little bit, you know, I talked to many of you who are, you know, organizational leaders, as well as, you know, community and facility leaders, but just, you know, trying to understand, you know, is it licensed nursing? Is it direct care staff? Is it combinations of both? But, you know, where are those pain points, and what are the ways that we can support you and work in collaboration with DHS, OHA, local public health, and, you know, think broadly, you know, are there in-home care agencies that, you know, can bring resources to bear? Does the Home Care Commission at DHS have a role to play? So, you know, that adage of how do we think outside the box a little bit, and who are those that we can align with to support the needs of those that we serve.
We do have a question. Do you have a minimum size requirement for a COVID unit?
No, however, it does need to be clearly segregated. So, you know, we have, for example, we have one building with 3 floors, and we've only contracted with the 3rd floor. We have another campus that has several different pods. We're only going to contract with 1 pod. So if you had, you know, like the 4-wing arrangement, you could segregate 1 wing and make that a dedicated COVID unit, but it would need to be separate and distinct. The staff members that are working there would have to only work in that unit.
Okay. Can DHS assist us with lifting restrictions on any programs that have been lost for 2 years?
I'm not following the context. Linda, do you know the context of that question?
It is so for when there have been certain types of citations for nursing facilities, it can potentially, CMS will then not allow them to have an NA program going in their community. And Jack, I don't know if you and your team, I know that there are some strategies around that. It's a pretty tough one because it is a federal rule, but
That's Linda, that's pretty much what I was going to say. Unfortunately, there's not a universal answer to that. It really does have to be, we have to look at what the situation is. We are, we at the state are willing to be as flexible as we possibly can in every area that we can be to ensure success in our buildings. So have that conversation with the nursing facility program. As Linda said, this is a CMS program, and we often aren't able to lift restrictions, but we will work with you.
I think there are some creative strategies that fall within the guidelines of CMS. And I think this is one of those areas, Steve, that I think if we can have, some joint efforts. So if, one building has maybe a restriction on their CNA training, but can we do training in a neutral location and do some cooperative work around that? I think that's a strategy. Or having contractors do the training, because technically you can't host it or do the training, but there are some workarounds. So I think that's definitely worthy of more discussion. As well as, there is an online, CNA training program that does, provide some additional flexibility. So I think, combining, getting the personal care assistance in that we do have a waiver for, getting those folks up and trained, and then, stepping them into, the CNA training program.
Okay. Just a follow up to the NA question, is there a consideration to relaxing the NA ratios?
Hi, this is Jack. No, we have not made any consideration of relaxing ratios for nursing facility nursing assistants.
Can the hospital consider a pause on hiring a nursing facility or community facilities? Maybe a 6-month pause.
Can the hospitals consider a 6-month pause on hiring? Is that the question?
Yes.
So, and maybe the question is, is it for more of a expedited licensing, or?
Can you clarify that question, Steve?
And I think that is one area that we're going to explore a little bit more. I'm getting some feedback that there could be maybe more efficiency with the Board of Nursing. I know that they have the ability to fast track under the governor's emergency order the licenses, particularly for out of state, licensed and certified individuals. So we really need to make sure that we can get timely responses from OSBN, particularly at this point, when we are facing such pressures.
Okay, clarification, the nursing facilities are losing most of the staff to the hospitals. So he's asking, can the hospital consider a pause on hiring?
Okay, so so for Jessica and Rachel, you're hearing that there's cannibalization of the labor pool, and the facilities believe that their staff are being cannibalized by the hospitals who are experiencing similar. So we can share that with policymakers in Oregon Health Authority. I don't think we're going to be able to solve the problem. So I mean, frankly, if the suggestion is to ask hospitals to pause hiring for any period of time, I'm almost certain that that's dead on arrival. Because hospitals need to hire staff too.
Yeah, and Mike, I just want to connect, you know, it's not just the long-term care facilities that are identifying shortages right now for staff. It is also the hospitals and EMS providers as well, and others. So that's just not something we'll be able to do. So that's why I think thinking holistically though about how do we help. I like, Linda, where you were going with some of the CNA strategies, and how do we help one another with additional training programs to ensure that we're increasing the workforce are great strategies.
Well, and I think the other potential is, you know, if there are solutions around creating some kind of a licensed nursing pool that, you know, we're not pitting against one another. I mean, so maybe they can work in, you know, acute care, or they can work in long-term care, or we've got people who are, you know, specifically trained for the long-term care setting, and really recruiting for that in a way. But I think that's one way we're going to have to look at this, is having some kind of a localized pool that we can draw from, and that would be prioritized to impacted buildings potentially.
If we have an outbreak and run short on staff, are we fined for this?
Well, this is,
Please, Jack.
yeah, I mean, this is a tough question. The issue is, you know, the ratios are there for a reason, which is this is the number of nursing assistants that's deemed minimally necessary to care for those residents. When you've also got COVID, you know, the care needs increase. I can't really say that you won't be fined for it. Again, we are being flexible where we can and when we can. And this is part of the crisis that we're here to talk about today, which is that shortage of staffing. So, you know, we will work with you. We will talk with you, but we do expect that you've done everything that you can to ensure that you have the staff that's available.
And that's why, you know, today we're saying, you know, a marquee building needs to have an agreement with an Avamere building. Those that we're encouraging creative thinking, because solving a staffing crisis is a longer term problem solution. It's not going to happen quick, and you're in the middle of a crisis now. And so that's what we're urging you to do, is to think creatively about how you're going to get through these next few months.
And I would just add to that, you know, we're continually advising folks, you know, to look at your emergency plan, which does need to include that pandemic response, which should also include what are your staffing strategies, because I think that's where you'll avoid, quote, the fine, if you're just sort of, you know, winging it with a staffing plan versus kind of what you have designated within your pandemic staffing strategy. How are you going to use potentially, if you've got outside resources, sister organizations, that gets harder, you know, if you're an independent, and that's where I think these community connections with one another are going to be vital, so that, again, we're supporting each other throughout this in creative ways.
So to my fellow panelists, I'm going to make sure you're not being shy. If you have something to say or to contribute, please don't hesitate to unmute and speak. Okay, Catherine.
Okay. Any thoughts given to develop a team to assist centers with testing and with staffing training? The challenge seems to be testing in smaller centers with fewer personnel resources.
I need to punt that one to either OHA or Jackson County Public Health.
I do have a lot of thoughts about the testing issue, and I think I mostly would need to be hearing what's happening on the ground. But I suppose most of you are aware that the dilemma is we have rapid tests that give us answers in 15 minutes that in certain circumstances are not as accurate as PCRs that can take days and days to get the results back. And I think we all know the consequences of being afraid you're in the middle of an outbreak, waiting 4 days for a test to come back and realizing, oh yeah, we were, and then you're too late. We have access to tests called Binax now, which have been distributed, I think, to these facilities as well as public health. It's a rapid test, it's an antigen test, and although we're not supposed to be using it for surveillance, in most of the nursing homes now, we're not dealing with a pure surveillance situation anymore. We're dealing with a high-risk population with risk of COVID, and they can be appropriately used. I'm thinking that with proper guidance and perhaps some degree of medical oversight, the facilities could look in a different way with how they're utilizing testing, utilize Binax now, perhaps with PCR as a follow-up test. But the problem I think that we're facing is that things happen very quickly. You really need to get results from your testing very quickly. And I'm wondering how we could utilize that resource better.
Hey, Jim, this is Rachel from the COVID Response and Recovery Unit. And I wanted to just jump in with a few items there. Just to confirm, so I know the nursing facilities have received the antigen devices, and especially if you are in a positivity area, you've also received allocations, I believe, of those Binax now. Additionally, those assisted living and residential care facilities who might be on the line as well have received some of those supplies. And so you are correct that in the specific clinical guidance that OHA issued for long-term care facilities, it differs a bit from the general antigen guidance in that because the antigen tests were issued as a federal resource as part of the federal response and asked to consider this for the requirements for routine testing of staff, OHA has identified that use of the antigen test are appropriate for surveillance in the staff testing for this population. You'll also note that the OHA guidance does now require, and this just was issued a few weeks ago, the updated guidance to clarify that if there was a positive antigen result, we are asking, or excuse me, if an asymptomatic patient had a positive antigen result, we are looking for the follow-up PCR confirmatory test right now. And that was guidance that we just issued to clarify as well. So you are correct that that is, we know, causes some challenges as well. I just want to acknowledge that your leaders have done a very good job and continue to advocate and escalate some of the challenges Linda has raised and others have raised that we need to consider. This is a very complicated dynamic when sometimes the state has differing guidance from the CDC, and we understand that. We're going to continue to take that back under advisement. And we realize that stay tuned, especially as we come in surge. We know that we need to monitor and assess how we're maximizing our testing resources.
Would DHS increase reimbursement to pay students in the NA programs for the 6 weeks of training?
So we currently have a CNA reimbursement program. So the question is, would we increase the rate that we pay? So maybe, so that's my answer, maybe. Please route any specific proposal or ask through Linda Kirschbaum, and she can get it to me, and I can look at our regs and rules and see if we have any flexibility in that area.
Yeah, Mike, I think that's a great example of the type of what are the barriers and where is it that we can be partnering to look at. So I think that those types of the CNA discussions and barriers that we've heard today are some great items to take back.
What is Oregon doing to provide incentives to RNs to relocate? Can they do something?
This is Rachel. I'll jump in here. I think that's something that we will take back as well and make sure as we continue to talk to our the nursing board and with our health security preparedness leaders at OHA, understanding what options are available and what that will look like. So I can't speak to that directly in terms of what Oregon will do, but I think it's great, again, for continuing to hear those ideas and proposals that we can try to all advocate and understand if that's what we need to do during this crisis.
So, Catherine, I'll do the OSBN one. So this indicates that OSBN denied fast track on a nurse's license because the facility was not a COVID positive facility. So we may need to have some conversations or interagency conversations to tease out those policies.
Are communities keeping staff on site 24/7 who are working with positive cases?
This is Jack. We have not seen facilities keeping staff on site 24/7. It certainly would help with the risk of exposure, but most providers probably do not have the capability of doing that, and staff certainly would have the right and the choice to go home. So we have not seen providers doing that as in general practice.
I do know that in some cases, though, when there've been outbreaks, occasionally, housing or, at hotels or, to put up staff so that they aren't then going back into their family units. So for those staff that, do want to kind of do extra hazard pay, but we've seen some of that in certain cases where they're housing offsite, but and cohorting them with other staff as well.
Okay. Can the Board of Nursing open up the emergency lick approval for facilities that are not currently COVID positive?
So I think that's a repeat, right, Linda? So I'm adding a note, and I'm going to ask members of the crew, COVID Response and Recovery Unit, to try and initiate dialogue with the Oregon State Board of Nursing, because they may not understand just how acute the crisis is right now.
Okay, and OCA stated there would be an additional guidance for positive antigen with negative PCR tests. Can you clarify further? Would the PCR negative override the antigen positive in asymptomatic staff?
So do we want Jackson County to handle that, Rachel, or do you want to take it? It's that old issue.
I can say we're still advocating that we follow that, we adopt the CDC guidelines, which would be for an asymptomatic individual that tests positive with a antigen test, that there would be a confirmatory PCR, and that positive test not be counted. So there's still a lot of discussion, and as Rachel addressed earlier, so we're still working on that one.
And I'm not sure, I can't remember if we addressed this earlier, but there was a question about if you have an asymptomatic COVID-19 positive staff, are there situations under which they would be permitted to work? And Jackson County, please correct me on this, but my understanding that that decision is in your jurisdiction. If you could communicate that and how they would request that kind of waiver, putting you on the spot here.
Sorry, this was for an asymptomatic positive staff member?
Correct.
Yeah, there are actually requirements in the Oregon investigative guidelines that are published by Oregon Health Authority. They kind of lay out the steps to that. I don't have them in front of me of what needs to be met. For instance, though, we've had a facility where they've put, COVID positive patients and then have asymptomatic COVID positive staff provide care for those residents, in those cases. So it's making sure they meet those requirements and that it makes sense from an infection control and safety standpoint going through those requirements.
So the message is that it is possible. And Jackson, would they just get in touch with Jackson County Public Health to make such a request?
Yeah, well, they would. And part of it, if there's one case in a long-term care facility, there's contact with Jackson County Public Health. And through that process, that's where those conversations would happen and trying to develop a plan to do that. Yes.
Thank you.
And a question, could they work in a positive COVID hall?
It depends if they meet all the requirements that are laid out in the investigative guidelines. Again, my apologies for not having those. I can't recall off the top of my head, but there'd be a discussion and a written plan to review and go through that.
Have you considered looking at allowing RN students to work as staff with reduced oversight requirements?
And Jack, unmute. And to clarify, are you talking about serving as an RN?
Tom, can you clarify that question? Yes.
Yeah, I need to punt that one to Jack.
They wouldn't meet the requirement of a registered nurse, of the requirement for the facility of having a registered nurse on site. If this is a NIF question.
But they certainly could fill NA positions, and I know the guidance on the personal care attendants indicated that if it was a first year nursing student, that they could be hired and they didn't actually have to go through the curriculum.
So that
For
can they work
CNA.
as a CNA?
That we could look at that. I can't give a definite yes right now because there are a few things that I would need to just research a little bit as well. But working with the NIF program, we could look at that definitely.
Okay, just a comment. Staffing agencies are requiring COVID quarantine pay for any symptoms. Their staff report high charges for working in a COVID facility and sending staff from miles away just to collect travel from facilities. They're using many tactics to hold facilities in desperate need of staff. Any thought of placing regulations on what they could charge as a facility or charge a facility?
So we don't regulate these staffing agencies. I'm not sure that staffing agencies are regulated at all, if they're regulated as in-home agencies by OHA. I think my suspicion is they're not regulated at all.
Mike, I'm not able to speak to that. We'd have to take this back, and I think you're noting it's complex. We understand that it's these are considerations that we need to be thinking about as well as we're thinking about. We understand that you're looking at what payments that you're making to ensure staffing. I understand that with the market the way it is right now, this is a challenging dynamic. We'll take that back.
I would just make the suggestion too, if you have staffing partners that you know you would recommend and that might be good partners for the overall community, we'd want to know who those agencies are or those contacts. We're talking with a couple different groups who seem to be creative, and hopefully we can do something there. But you guys have a pipeline, or you have a better pulse on some of those groups yourself, and who might be better or best versus worst or worster. How's that for 3 o'clock, 3:30 on a Friday?
Linda, I think that's great. And I was going to note, that's actually something we'd love to even formalize. I know potentially we're looking at having a survey, maybe even just asking that to really get some input. That would be wonderful to really hear what those firms are.
Okay, one more question. What is working well in other counties for staffing? Appreciate any of the broad thinking.
So I need assistance with this one. I think that what we've seen is the utilization of staffing agencies. We've seen staff be flown in from other states. We've also, I can't count the number of times where, you know, a facility has a reduced number of staff, and instead of being able to care for 30 residents, they can only care for 20. And we've helped them find additional alternative placements for those other 10. We've helped a lot with that. Jack, anything I'm missing?
That's pretty much it. Yeah, the use of transferring a certain number of residents, working on, we've seen some facilities find success in finding and retaining staff by increasing what they're paying staff.
Yeah.
But I think that's really where we've seen success.
Yeah, the rubber hits the road there. You know, we are still a capitalistic society, and there is a rate at which you're going to be able to attract people. And some facilities are willing to go to that rate quickly, and others fight like heck. So.
Well, unfortunately, we are out of time. Thank you so much to our panelists. If I didn't get to your questions, please let me know. I'm happy to connect you with everyone involved here. This webinar has been recorded, so you can view it at your own convenience. We'll add it to our the ohca.com website under the COVID-19 information page once it's been processed. But thank you again for joining us this Friday afternoon. Again, email me with any questions, and thanks again. Have a good Friday, everybody.
Thanks everybody
Thanks,
for
everyone.
attending, and
Thank you.
I'm really counting on your leadership to get us through this surge. So thank you for being here today.